Good morning, everyone. Thanks for coming. It's great to see you today. We lucked out with the weather, so I hope everybody had a reasonably smooth trip in to the hotel this morning. We're going to go ahead and get started with the program and just have a few welcoming announcements. So if people start to see folks coming in and they have any trouble with chairs, just kind of wave your hands and we can either get some more brought in or we have some extras up front, but people should be able to find a seat, hopefully. So I want to welcome everyone and thank a number of sponsors and thank our team for organizing. So we've got several gold sponsors that are helping to support the food and other costs of the program today. Care.com Home Pay, the Mooney family, Finding a Cure for Posterior Cortical Atrophy, and bronze sponsors include Care Dimensions, Love is Out There, Overlook Care, and Residents at Valley Farm. So thank you to the sponsors for helping support the costs of the program today. And also to the agencies that provided resource tables outside that you may have been able to interact with so far and that will be here throughout the day, including the Alzheimer's Association, the Association for Frontotemporal Degeneration, Care.com Home Pay, and Care Dimensions. As also Overlook Care. And we have conference evaluations in your packets that we'd appreciate it if you fill out as we go along and give us feedback. We want to take your input to try to make next year's program even better than this year's, and we did that last year, so hopefully we targeted it towards some of the people who were here last year's interests. Let me just see a show of hands. How many people are here for the first time at one of our education events? Wow. Okay, wonderful. How many people are return attendees? Great. Okay, well, we have some new information, but we're also starting from the basics, so we're welcoming everybody, whether you've heard some of this before or not. So it's wonderful to see so many new people here in the community. And also, just so you know, we're filming today, and so we're going to work on getting the presentations on the web so that people who can't be here can access them and be able to look at them at your leisure or review them later if things go by too fast. So thanks to Katie in particular and to the FTD Unit team for organizing what I hope will be a fantastic day and that you guys will get a lot out of, and for our guest faculty who I'll introduce along the way as well. So I'm going to start out with a overview of the frontotemporal dementia spectrum of conditions, and I'll warn you up front that there's a lot of terminology, and I will do my best to try to explain along the way, but keep in mind that most of us medical professionals have some trouble with some of this terminology, and we're always teaching our peers, and so there will be plenty of opportunities throughout the day to ask questions and have discussion, and so please make notes about your questions. And the first opportunity will be all the faculty from the morning's presentations will be standing up here at the end of the morning session, and feel free to come up and talk to us about questions or concerns or anything on your mind. And then during the afternoon sessions, there will also be plenty of time for questions and dialogue. So hopefully things that pop into your mind along the way will be able to be addressed throughout the day. I just want to start by mentioning briefly that this is a painting by Sybil Sermos, who looked at the MRI of her husband and was inspired to try to paint her feelings that came out when she saw that MRI, and she traced, let me get this on, she traced some of the brain structures on here from the MRI scan. So I just thank you for sharing this once again, Sybil, which you did at the gala last year. I think I put it up at the beginning of a lot of my talks because I think that we spend so much time on the medical issues, and I think we do our best to try to acknowledge all of the emotions that come along with even something as straightforward as trying to talk about a brain scan. So just a little bit of history. It's been almost 10 years now since we began the FTD program, but before that, going back to 1984, Dr. Growden, John Growden, a neurologist at Mass General, who continues to be a mentor of mine, started the Memory Disorders Unit and the Alzheimer's Disease Research Center, which I'll talk a little bit more about. And this serves as an umbrella that we were able to start the specialized FTD program under, which Daisy Sapolsky and I started the Progressive Aphasia program in 2007, and then we formalized it into the FTD unit in 2008. So it's getting upwards of 10 years now. We did our first educational conference in 2009, did a research update 2011. The Association for FTD had their annual conference here in Boston in 2011, and we were part of that. And then last year, the fourth Education Day, and then our first gala last fall in October, and we'll be doing another one this fall. And today is the fifth FTD Unit Caregiver Education Day, and I want to really just take a moment to thank the program faculty and volunteers and the team who have put all of this program together. So let's just take a moment to applaud. Thank you. And I always like to say that we have to continue to promote partnerships in this community. This is a rare disease, as you know, or these diseases are rare, and we need partnerships. So this is some people who are here this year, and this is a number of people who presented last year. Katie has led the way at Rare Disease Day, which is every year at the State House. People from a variety of walks of life get together to try to raise awareness for and advocate for patients and families dealing with rare diseases of a variety of types, some of which affect kids, some of which affect adults. And so this is, I think, a wonderful illustration of the importance of partnerships. And this really brings together the pharmaceutical industry as well, who don't necessarily have a lot of incentives to develop medications for people with rare diseases, and so really need governmental incentives and other reasons to go after that. But we definitely see a strong representation of the pharmaceutical industry. And then partnerships of all forms to help us with fundraising. A lot of the programs that we'll be talking about today and ideas for new research start with seed funding that helps us get things off the ground, and we appreciate everyone that puts effort into those types of partnerships. So I just want to give a general overview of neurodegenerative diseases as they relate to the FTD spectrum. And so the way to think about it is these are gradually progressive, usually over years, conditions that affect cognitive, behavioral, or movement, or sometimes sensory functions like vision, and gradually cause changes almost imperceptibly at the beginning. And we try to draw these somewhat artificial lines when we make diagnoses, but the first thing I always say is we want to try to figure out, does the person we're evaluating have a dementia, which basically means they've lost independent functioning. So they have acquired some changes in their thinking or communication or judgment or other memory or other skills that have been significant enough that they need help now. They can't do things by themselves. Before that, there are often long periods of time when people have what we call mild cognitive impairment, or a related term that basically means the person is having some symptoms, whether they're language or memory or other symptoms, but they're still functioning more or less independently. So I usually say if the family can all leave and go on a trip for the weekend and the patient can get through the weekend by themselves, they're probably at the stage of some form of mild cognitive impairment. So regardless of exactly what the diagnosis is, I think this is an important determination to make up front to try to help counsel people about what services a person might need or what supports they might need, regardless of exactly their diagnosis. And then we believe that there are a number of years before any symptoms develop where the changes in the brain are starting to take place, and that's one of the topics that we study a lot. And the time frames of these categories are highly variable, and one of the things that many of you know we try to do is personalize our feedback to people about where they are in the progression and what our expectation is about the rate of change and what they can expect over a few years. But this process probably spans at least a decade or maybe more in many people. And it's due to the gradual accumulation of neuropathology in the brain, which we'll talk about. And these are proteins that have normal functions in the brain and that we're learning more about, but that start to lose their normal functions, and sometimes that causes damage to the brain cells, or sometimes the loss of the normal function just doesn't allow the brain cells to do their job anymore. So this is the short list. There's a much longer list, but this is the short list of neurodegenerative diseases that are in general related to each other. So a lot of times we talk about Alzheimer's disease and related disorders, and these are many of the related disorders. And in the Alzheimer's community, a lot of times people refer to Alzheimer's disease and related disorders for simplicity, but they're really talking about our conditions as well. And just as an example of that, the Alzheimer's Association has been working very hard with the federal government through their advocacy efforts. They have a branch in Washington, and just in the last few years, we've seen a real increase in the federal funding for Alzheimer's and related disorders research. So that includes frontotemporal dementia and related conditions. It's explicitly inclusive. So just in the last year, we saw the budget go from about $500 million from mostly the National Institute on Aging and the National Institute of Neurological Disorders, up to now more than $900 million, so close to $1 billion. The goal is to try to get it up to $2 billion. And Katie and others have gone to the advocacy forum every April. The Alzheimer's Association puts on an advocacy forum over a weekend in DC and goes and lobbies the legislators on Capitol Hill, and it's really the largest volunteer lobbyist group with more than 2,000 people that go down there and do that. So I would encourage people that are interested in that level of activity to consider participating next year, and there's very explicit involvement of the related disorders community, and it's having a direct impact on research. So some of the projects that we're trying to get off the ground probably are going to get funded this year as a result of that increase in funding, and they might not have last year just because the dollars only go so far. So these efforts are having a direct impact. But the conditions are Alzheimer's disease, frontotemporal dementia, which includes the behavioral variant of frontotemporal dementia, which used to be referred to as Pick's disease, and the primary progressive aphasias, and then something called posterior cortical atrophy. And these conditions are associated predominantly with cognitive and/or changes in mood or behavior, whereas at the bottom we have Parkinson's and ALS, which are predominantly conditions associated with movement or motor-related symptoms, but more and more we recognize that there are cognitive and behavioral symptoms that may occur and may become prominent in people with Parkinson's or ALS. And then a set of conditions kind of in between that are associated with a whole suite of to some degree varying cognitive, behavioral, or motor symptoms, and these include progressive supranuclear palsy, corticobasal degeneration, dementia with Lewy bodies, and Huntington's disease. So there are many ways that I think the clinical issues involved in these conditions and the pathology in the brain of these conditions are being revealed that give us insights. So for example, in the ALS community, there's research that has helped us gain insights into FTD and vice versa. So I think more and more we're recognizing that we have to be doing this work together, and I think there are more collaborative efforts around working across groups that traditionally have been doing things separately. So the complexity of FTD comes out at many levels, and I'll touch on that a little bit, but be aware that many neurologists, many psychiatrists, many not even just primary care physicians or other general practitioners, but specialists like neurologists and psychiatrists may not know all of the details of these terms. So don't feel like you're the only ones that don't understand this. I think many well-meaning medical professionals are having trouble keeping up with all the terminology and the advances. And you'll see that some of the advances have been just in the last 5 years or so. So these are not things that people were taught in their training days. So how common is FTD? We think it's the third most common of the neurodegenerative conditions that cause dementia after Alzheimer's and Lewy body. Alzheimer's is thought to affect maybe about 5 million Americans. Parkinson's may affect about 1 million. And FTD may affect somewhere between 50 and 150,000 Americans. It's really not clear, and we think these are probably underestimates because it doesn't often, as you know, get diagnosed very confidently. But there have not been good epidemiologic surveys of how common FTD is, and so I think these are just guesstimates essentially, and there's more effort to try to figure that out. But it's probably the most common form of dementia in people under the age of 65, so-called young onset dementia. So when you're working with people under 65, it may be just as likely that the person would have FTD as it is Alzheimer's, so in younger people. as you know. But cases have been reported with onset as young as in their 20s and as old as in their 80s, and our own practice spans people from age 27 to age 86. So just because a person is in their 80s with dementia doesn't mean it's not FTD. And up to a third of cases have a positive family history, and Diane Lucente will talk more about familial and genetic issues related to FTD. So as I was saying earlier, the way I like to think about how we understand frontotemporal dementia and primary progressive aphasia is to think about the overall clinical status. So what's the set of issues that the person is having trouble with and that we can measure when we do testing or other types of evaluation. And we think of symptoms as the changes in a person that are being experienced at home and are visible to them, and signs as changes that we can test for in the office in our evaluations. And these ultimately lead us to be able to diagnose people with primary progressive aphasia or behavioral variant frontotemporal dementia. And these criteria for diagnosis just came out in 2011. So even though people had been making these diagnoses before that, there is an update that has changed the way that the diagnosis is made fairly recently. And we've been developing new scales to try to measure the symptoms in these conditions. And we do a lot of work with other centers around the country that are called Alzheimer's Disease Research Centers, but they also do work on FTD and related disorders, and there are about 30 centers around the country. And some of what we do is try to pool our data to understand the natural history of these conditions so that we can make better predictions or better estimates of how to monitor them. And with behavioral variant FTD, we see these symptoms that include loss of your filter, people doing things or saying things that may not be appropriate to the situation, apathy, loss of sympathy or empathy, a lot of the issues related to interacting with other people, loved ones, or in social settings, whereas the progressive aphasias tend to be more specifically associated with changes in language and communication, which Megan Quimby will talk about in a moment. But in general, the condition starts out distinctly, usually, as one of these variants and gradually progresses to involve other domains. So people with behavioral changes may develop language changes and vice versa. And depending on the type and location of changes in the brain, sometimes movement changes may occur, and these have been some major topics of recent FTD conferences, and they may look more like Parkinson's with incoordination and slowing and stiffness, or may affect swallowing. And in general, survival is 2 to 20 years with an average of 7 to 10 years, but it all depends on how early the diagnosis is made as to how long it seems that the person can function. Treatments we'll hear more about from Dr. McGinnis. Nothing is proven to work, but there are a lot of things that we try, and I always say that treatment is not just medications. It includes a variety of things that we try to deliver in a comprehensive, multidisciplinary way to improve and maintain quality of life for patients and families. So we think that every person has a condition that can be treated. It may not be possible to stop it or reverse it or change what ultimately is going to happen in the brain, but it may be possible to change the patient and family's experience in living with the illness. So that's really our approach, as many of you know. And I'm just going to go quickly through some of the changes in brain anatomy and function. We do MRI scans in most everyone that comes for an initial diagnosis, and sometimes there is shrinkage in certain parts of the brain that we link to the symptoms that a person is having from those parts of the brain changes, and that can tell us more about where the changes are and how severe they are. And we can make measurements of these with some of the computational tools that we use over in the Navy Yard, Charlestown Navy Yard, to measure the size of different brain structures, and ultimately you can see those changes. For example, in the left temporal lobe of this person, this is as if she's looking out of the screen at us. There's shrinkage over here and not so much over here. And if you make measurements of the thickness of the cortex, this gray ribbon here, you can see the left side being affected more than the right, and we can make these maps and try to quantify the change and follow them over time. So these are some of the ways that we hope we'll be able to tell if treatments of various sorts change the progression of the illness. And then PET scans are done for a variety of purposes, but glucose PET is a scan that's often done as part of the diagnostic process. And if the frontal lobes or the temporal lobes have reduced function, then it's more consistent with FTD, whereas if the back of the brain has reduced function, it's more consistent with Alzheimer's disease. So there are other patterns as well, and the PET scans can also tell us about the function of the brain as to whether it's mildly affected or more severely affected, because the brain should all be very active and having a lot of glucose metabolism that's shown in the red colors here. So we often go over this with people in the clinic when we meet with them. And we hope these imaging markers can help us with earlier and more confident diagnosis, prediction, and monitoring over time, and ultimately help us tell whether treatments make a difference. And just to finish up the last part of this introduction, I'll talk a little bit about brain pathology. So if you look at the brain after a person passes away, you can see that the frontal lobes are quite shrunken in many people compared to the back of the brain. And the reason for this is the loss of normal cells in the brain. And you can see that under the microscope with loss of brain cells, these little clear spots here where there should be cells, and the accumulation of abnormal forms of proteins that can be seen under the microscope. And where they occur determines the symptoms. And so there's tau protein and there's TDP43 protein, and then some people have atypical forms of Alzheimer's. As many of you in the room know, when a person passes away, even if they've had progressive aphasia or behavioral FTD, they may turn out to have Alzheimer's pathology in their brain, and we're often surprised by that, and sometimes we think we may be able to predict that, but I think there's not a one-to-one relationship between the symptoms that a person has and their pathology. So this is just an illustration of the complexity of these relationships. So here, if a person has the semantic form of progressive aphasia, which Megan will go into more, they're highly likely to have this type C form of TDP43 pathology. So there are these probabilities that we can try to use to predict the likelihood that a person will have a certain type of pathology. But you can see with the behavioral variant of FTD, it's a full rainbow, which basically means you could have any of these pathologies. And ultimately, most of them have a little gray bar over here on the right that indicates that it could be Alzheimer's. So we do the best we can to try to predict or estimate what the pathology is in living people, but we don't have great tools for that yet. One of the tools that's really revolutionized things in the last 10 years is so-called amyloid PET. So this was a man that was suspected as having possible Alzheimer's, but he had a lot of frontal lobe atrophy and loss of function in the frontal lobe. And when he had this particular kind of PET scan called an amyloid PET scan, it's completely negative. That's what the blue means. And so that means he does not have Alzheimer's pathology in the brain, and he turned out to have FTD. So some of these pathologies are now being able to be imaged in living people with some of these specialized kind of PET scans. And many of you have heard about the tau PET scans that we've been trying to develop at Mass General and that other groups around the world are working on to try to measure some of the other proteins that we don't have good measurements for in living people. So I think I'll skip this for now. Some of you know about the stem cell program that we're working on, and I'm happy to talk a little bit more about that later on. But the effort is really to try to model the disease better and be able to screen for treatments. I just want to close by summarizing some of our mission. So in terms of clinical care, we're aiming to do the best we can to provide comprehensive diagnostic evaluation and treatment along the lines of what I'm talking about, which is mostly supportive and treating certain kinds of symptoms at this point, and we'll get a little bit more into that, to provide social support, genetic counseling, and autopsy services. We think these are fundamentally important services that people should be getting when they're dealing with one of these illnesses. And then education and training of the next generation. We have a growing list of people that we've trained in speech pathology, neurology, psychiatry, internal medicine, psychology, and neuroscience, many of whom are here and that you have met. And we think it's critically important to try to educate the next generation of clinicians and scientists to understand these diseases better. And you'll often meet people in their training in the clinic or in the research facility. We also train our peers. We have an annual dementia course every year in May or June that is in its 20th year this year. That is for doctors and psychologists and social workers to try to learn more about the whole field of dementia. It's a 3.5-day course. And then my colleague that runs that course with me, Dr. Atri, and I took the presentations, many of them, and turned them into a book that came out in 2014. And I was fortunate to be able to edit a book on FTD that's coming out next month that will be the hopefully comprehensive medical reference for FTD for specialists and non-specialists. And I'm hoping that Katie and others will be able to work with me to take some of this material, and we're going to submit a proposal to do a book for lay people on these conditions And some of that is going to involve potentially telling stories about people's experience with certain kinds of symptoms so that it can be a reference for people who are just getting into this community. And for those of you who are interested in telling your stories, we cherish that activity and partnership, and we may be able to work some of that into a book that we hope to develop in the not too distant future. And then the research you'll hear more about, but is to try to develop better methods to assess the kinds of symptoms people have, to objectively measure problems with performing certain kinds of tasks on the computer or on pencil and paper, to advance imaging technologies, and ultimately we want to improve the accuracy of early diagnoses, be able to predict what's going to happen, monitor what happens, and ultimately identify rehabilitative and other strategies to improve daily function, as well as medications and other treatments that can hopefully slow down the progression and improve quality of life. And there's a list of some of the studies we're working on, but there's a growing effort to try to work together as a North American and even worldwide consortium of centers working on these diseases, and we're seeing more support from the federal government for these kinds of infrastructures that are required to enable us to collaborate. And this is one example of a familial FTD consortium that just got off the ground in North America, and there's a similar one in Europe that is aiming to try to enroll everybody with one of the genetic forms of FTD into a natural history study so that we're ready to roll out clinical trials of medications when the time is right. And we'll hear more about that from Scott. So ultimately, what we want to do is try to use all these tools to not just monitor what happens, but to institute some kind of disease-modifying therapy that will slow down the accumulation of the pathology, slow down the changes in the brain structure and function, and eventually prolong function and even improve function, we hope, in people with these conditions. I think it's not a dream, but we still have a lot of work to do, and it's through partnerships like this that I think we can connect with you in ways that will ultimately, I hope, lead to more effective therapies and care. And I just want to thank, again, you and the team for helping us bring us all together to accomplish these goals. Thank you.